I'll start with case 1. It's referred from Dr. Vivek Jain. This is a 7-year-old male child whose sibling also has a similar clinical phenotype. Both are affected with facial dysmorphia in the form of long nose, smooth philtrum. Both the hands demonstrated syndactyly and patients had short stature and appear to thrive. Both the siblings have severe intellectual impairment with autistic features and bilateral lower limb spasticity. The male child demonstrated developmental regression after 2 years and is still ambulant. The blood lactate, TMS, and the urine organic acids are negative. If Dr. Vivek is there and would like to add anything to it or describe the features.
So yeah, essentially that's it. Both children are similarly affected. The 7-year-old is the older sibling whose MRI you'll be showing now, and the younger one looks the same spastic diplegia with autism and dysmorphism. His metabolic workup is negative because I did organic acids because of thinking of possibility of glutaric acid, this L2-hydroxyglutaric aciduria. And his lipid profile is also normal. You will see why I did it when we do the MRI. We'll look at the MRI.
Okay. So here we have the MR images. On top are the axial T2s. Here you can appreciate that there is a lateral ventriculomegaly. There is some reduction in the posterior periventricular white matter. No cortical malformations. Deep brain nuclei appear to be relatively normal. No signal changes along the periventricular regions. Coming to the posterior fossa, you can appreciate that there is prominence of the interfolial spaces with symmetrical changes of high signal changes on the dentate nuclei. On the sagittals, the corpus callosum is diffusely thin. Again, you can appreciate the cerebellar atrophy. Brainstem demonstrates normal volume. Again, the coronals, you can appreciate the symmetrical dentate nucleus changes. Similarly, corresponding hypointense changes on the T1s. Diffusion sequences, I could not appreciate any restricted diffusion. SWI sequences, again, no abnormal changes on the SWI. Spectroscopy was done with voxels in the basal ganglia, thalamus, and also the frontal white matter. There is a lactate peak, small lactate peak around 1.3, and I cannot find any other diagnostic peaks on the MRS. So if you want to concentrate on the posterior fossa findings of the dentate nuclei, there are a list of conditions which present with these changes: metabolic leukodystrophies, neurodegenerative and inflammatory conditions. Since as the patient also has some degree of cerebellar atrophy with dentate nucleus changes, these are the possible differentials based on only the infratemporal changes. This is a paper from Dr. Bolthauser et al. And these are the possible imaging differentials: succinic semialdehyde, dehydrogen deficiency. They usually also have globus pallidi changes. Mitochondrial can also, though has symmetrical change in dentate, but can also have brainstem changes, and also in the supratentorial region, the dorsal striatum can be involved. Glutaric aciduria again demonstrates symmetrical changes, but there is supratentorial changes which are not seen in our case. L2-hydroxyglutaric aciduria, as Dr. Vivek has pointed out, is a possible differential, but again, the supratentorial white matter leukodystrophy type pattern is not seen. And CTX also demonstrates these hyperintense changes, but the clinical picture does not correlate with the imaging findings. So we are thinking of if the supratentorial changes are possible related to perinatal insult or not. I'm not sure. And I think the dentate nucleus change and the supratentorial changes are maybe different, not of the same pathology. If Dr. Mankad or Dr. Biju or anyone wants to comment on that.
I just wanted to ask a couple of things. So what age was the brain scan done at?
7 years.
7 years. And from a clinical perspective, is this looking neurodegenerative or a static problem? And of all the differentials, which of these actually gives syndactyly as a component?
So even though father said that till 2 years there was some progress, and after that the children haven't progressed much, I don't think it's regressive, it's more plateauing. And so I won't say they have a neurodegenerative disorder. They have more of a disorder where they have plateaued to a level. And syndactyly, yes, I couldn't find much where one can have syndactyly with dentate hyperintensity. Both children have syndactyly.
Thanks, Vivek. Good to hear your voice as well.
And what were the clinical findings in terms of the gait abnormality?
So both children, they both have lower limb spasticity, spastic diplegic gait. They're not ataxic. It's more so narrow base spastic scissoring gait.
So these children, both of them never walked. As in, like, when did they start walking?
So they both were delayed. So they're both walking now. Actually, they're both ambulant, and one of them walked at 4 years age, and the other younger one has just started to walk. I think he's just 3-year-old.
And then the MRI which we saw was of the older child, isn't it? Older sibling.
Yeah, older child.
Yeah. Who started walking at 4.
Yeah, and he's 7 now, and done just now the MRI.
And the pattern of spastic diplegia is exactly the same in both the children.
Yes, same. The younger one has still not become as spastic as the older one, but he's evolving into one.
So the spasticity is progressing.
So spasticity, yes, is so if one says, it's very difficult to ever say whether it's progressive or it's just the muscle tone changes. So yeah. So maybe spasticity is so often it's very difficult. Even in a spastic CP, when they have more of a muscle tone problem which gets worse later, one cannot say if the disorder is progressing or the motor tone is changing, muscle tone is.
No, then that is that that's dystonia, which doesn't get better with time. And in terms of spasticity, you mean they are developing contractures over time?
So the contractures in the older one has, so it's not contracture, there's some dynamicity still. Definitely there is no dystonia.
So in terms of relating it to Kish's question, we're thinking of something progressive, isn't it?
So cognitively wise, they're not deteriorated. So motor wise, if one says yes, spasticity is progressing, there is maybe some degree of motor degeneration, motor progression, but cognitive progression is not there.
And the
Cognitive
callosal
regression is not there. Cognitive regression is not.
The callosal hypoplasia and the underdevelopment of the cerebral hemispheres would go with that theme as well, I think. So you're potentially targeting the hereditary spastic gene panel here, isn't it?
Yeah, with dentate hyperintensity and
some of them can give cerebellar atrophy and dentate changes as well.
But do you see any of them SPGs with dentate hyperintensity and syndactyly, or just dentate hyperintensity even?
Correct me if I'm wrong, Biju, but you can get syndactyly in the context of hereditary ataxias and spasticity syndromes, isn't it? I mean, there's a whole list of those genes.
Theoretically, I'm sure it is possible. Now, the difficulty, the syndactyly, I mean, I haven't seen, but I'm sure it should be possible. Anything is possible, isn't it? So
it's more if it's this SPGs, it's the dentate hyperintensity which tends to, muddle the plot. So yes, one can have so many cerebellar atrophy, thin corpus, SPG, but with dentate hyperintensity.
Yeah, I think Eugen will agree with us that the dentate hyperintensity is sometimes not even seen or described properly. So there, I mean, one of the things I wanted to ask Nihaal was the bit of the cervical cord you see, does that look a bit thin?
That will be a bit difficult to say. Maybe, but we don't have the section.
Again, it could go with the spastic paraplegia syndrome.
Yeah, the only doubt was of the dentate. Otherwise, I think it would fit into spastic paraplegia.
And also, when it comes to spastic paraplegias and cognitive effect, it's a very messy field, and the ones which we have worked up, sometimes you get dual genetic diagnosis, cognitive involved, because some of the children don't have much cognitive deficit at all. And when you see both of them, and sometimes when you work them up, you sometimes get dual diagnosis. But the progressive spastic paraplegia seems to be a hallmark in this one.
I have no suggestion of call. I think you will depend on very good genetic analysis. Yeah, I don't have a good clue. This is, I mean, these are identically, similarly affected siblings. This is something genetic. We have no doubt. Yeah. The metabolic disease is listed by Nihaal, I think, in terms of lack of basal ganglia or white matter involvement are all more or less out, apart from mitochondrial, which can make anything.
Okay, Dr. Vivek, is it being sent for whole exome? I think that was what you mentioned.
Yeah, so try whole exome, hoping to send few days when they come next visit. Yes, I'll keep you updated.
Okay, right. Thank you.
Would the whole exome capture the HSP panel?
Yes, whole exome. See, one can just do a SPG. So whenever one does whole exome, you are looking at a wide range of problems. So you cannot be just concentrating on SPG because it must be something else, might be. So therefore, one has to do whole exome, and it does cover the panel. It will not cover it as well if you just do the panel, SPG panel, but it will cover well enough to cover other disorders which are beyond SPG. So we cannot risk doing just SPG because you know the cost issues. Family has to pay for it. So you do just the SPG panel and then you end up doing trio. So best do a trio which will cover it fairly well.
Thanks, Vivek. We agree.
Okay, right. Thank you. Moving on to case 2 is from Dr. Ramesh. It's a 6-month child with developmental delay, horizontal gaze palsy, bilateral abduction issues, adducting nystagmus, and hypertonia. Dr. Ramesh, if you're here, anything to add? Or should we? Okay, I'll go to the images, which is pretty pathognomic. So here the axial, you have the T2 images. For a 6-month child, the brain in the suprachoroidal region appears normal. The predominant changes are in the posterior fossa. You can appreciate this tent-like shaped fourth ventricle, absence of the facial colliculus. The sagittal images demonstrate an abnormal brainstem. It is slightly flattened. There is some concavity on the dorsal surface of the pons. The medulla is slightly thin, and the axial images of the medulla demonstrate this inverted butterfly-like shape with prominence of the medullary pyramids in comparison to the inferior alveolar nuclei. And I can appreciate the tent-shaped appearance along the dorsal aspect. The CIS images better demonstrate the findings. Again, you can see that the normal brainstem, which the presence of the facial colliculus is absent, giving away this dorsal spix sign or the tent-shaped appearance of the dorsal brainstem. The pyramids are prominent in comparison. The alveolar nuclei are prominent in comparison to the pyramids. This is the normal structure of the axial section of the medulla. And also the brainstem, in comparison to a normal brainstem, you can see that it is slightly sagging. The belly is slightly sagging, and there's some dorsal concavity of the pons which should not be there. So based on the imaging findings alone, one must think of ROBO3 mutations responsible for horizontal gaze palsy with progressive scoliosis. Another imaging differential which can be seen with almost similar brainstem findings are the DCC gene. But the DCC gene has abnormal corpus callosum in the form of agenesis or hypogenesis. This is just an outline of the abnormal brainstem. If there's a dorsal pons enclave with a butterfly medulla and there's a corpus callosum abnormality, one must think of DCC, and if not, one must think of ROBO3 mutation. The scan was done recently, so I don't think we have a genetic diagnosis, but we're pretty confident of the diagnosis of the MR.
Eugen, what do you think about the cerebellar-Warmian ratios? Is that a ROBO3 feature? There's disfoliation as well, right?
Can you repeat the question, please?
I think the brainstem configuration is quite typical for ROBO3, but I was just thinking whether the additional cerebellar abnormality, whether the Warmian ratios are normal, or Nihaal, you've drawn some lines there. Were you trying to show that basically?
No, this is just a normal.
Okay, if you just go
normal
back one
motion.
step, if possible.
Yeah.
Yeah, I just thought that there was an abnormality of the cerebellum as well, which I don't think has been described with Robo3, but must be associated.
Yes, I agree.
And the other feature of the downsloping splenium, which is very non-specific, but hints at a neurogenetic problem, mostly pertaining to the posterior fossa.
How old is it now?
6 months.
6 months.
Yeah, the scan was done at 6 months.
Some of these patients can have very early scoliosis already in the 2nd year of life.
We didn't get a spine done, but yeah. I thought it was too early for the scoliosis to present.
Fairly pathognomonic, Nihaal, I think, but the cerebral findings would be additional, not described previously, I think. There is a group in Boston collecting Robo3s from all over the world. If you do get a confirmation, I can put you through in contact with them.
Okay, thank you. Moving on to our next case. It's a 5-month boy with related macrocephaly, dystonia, developmental delay, irritability for around 10 days, associated with fever and decreased speed for the last 3 days. The child is a firstborn child born to 3rd-degree consanguineous marriage. Clinically, there was a suspicion of glutaric aciduria. And as you can see on the MR images, we have symmetrical abnormalities involving the dorsal striatum or the basal ganglia, the underapicalized ciliary fissures, widened ciliary fissures with subdural collections in the anterior and lateral convexities, symmetrical changes of the dentate nucleus, and also some subependymal cysts or paraventricular cysts along the bilateral lateral ventricles. The corpus callosum is thin, and the flare you can see that there is bilateral subdural collections more on the left, no abnormalities on the SWI. So this the constellation of findings I would think fits into glutaric aciduria, subdural collections. These are the differentials. Subependymal cysts and dorsal striatal changes, again glutaric aciduria. If you want to see approach in a pattern recognition way, and the common features are present in our case with the clinical findings. This has not been sent for genetics yet, but I think the imaging and the clinical scenario is pretty straightforward.
I agree. This is absolutely classical constellation, clinic-wise and imaging-wise.
Absolutely.
Yeah, I wanted to know from my colleagues in India, how do you confirm the diagnosis? Is this of GA1? Maybe Lokesh can tell us. Whilst Lokesh is unmuting, Nihaal, what about the cerebellar changes in glutaric aciduria?
You mean the dentate? They're described.
Yeah, quite extensive in this case, isn't it? We don't often comment on that.
Yeah, but I think we have seen few cases. I mean, we've seen cases with dentate changes.
Can I add a clinical observation or an epidemiological one? In some countries, glutaric aciduria is now included in the newborn screening. And there is a subset of patients in the order of 3% who are so-called low secretors. And these are missed by the newborn screening. So if a child later has features like macrocephaly, dystonia, and so on, even if has passed newborn screening, this should be considered and confirmed by genetic testing. And these patients also have low amount of glutaric acid in the urine. So organic aciduria, organic acid will also miss these few patients.
Mm-hmm.
So should I attempt, Kshitij, your questions answered?
Yeah.
Yeah. So usually for glutaric aciduria, if we suspect clinically, we do a TMS, so tender mass spectroscopy, which is like same as doing it on a Guthrie card blood sample as done for newborn screening. And what we look for is, glutathione carnitine. So the code word is C5DC in TMS. So that will be significantly high in an ideal situation. So that's what is the first test one does. And there are a group of patients who are low secretors, so where the TMS can be normal. So if you're really suspecting it, and if TMS is normal, you should not stop there, then you should do the exome sequencing for the gene.
Thanks. It's good to know how they're worked up.
But it's standard practice now for genetic testing in all of them. Yeah. Okay.
Okay, thank you. We'll move on to our next case. Case 4 is from Dr. Mary from Sri Lanka. It's a pretty extensive history, but I think it'd be important to go through. It's a 9-year girl, first presented at the age of 10 months with focal seizures, followed by left hemiparesis, which lasted for around 2 to 3 months. The episode was associated with fever, which lasted for 3 days initially. Since then, she has had episodes of focal seizures with left hemiparesis, which have lasted for 1 to 3 months, and clinically thought of as Torr's paralysis. The right eye lesion, which we are thinking of a melanoma or a vascular malformation, was present since birth and has since progressed. EEG at 1 year and 10 months had no epileptiform discharges. For at 10 months, had asymmetrical abnormal background compatible with underlying structural abnormality in the right hemisphere. There was no cutaneous abnormalities. Birth and parental history was unremarkable. At infancy, the growth was less than 3 standard deviation with poor school performance now, poor compliance to drugs and other medical interventions. If Dr. Mary is there and would like to add.
Shall we proceed with the imaging?
Yeah, so just to add, they tried to biopsy the eye lesion, but unfortunately the tissue sample was not sufficient, so we could not get a biopsy of the eye lesion. So we'll go through the images. First, external scans at around age of 10 months, this is in 2013. And you can appreciate that there is asymmetrical dilatation of the lateral ventricles. The right is more dilated than the left, which is normal. There's also some asymmetrical atrophic changes in the frontal lobes on the right side. And also the middle cranial fossa demonstrates the CSF collection, which suggests to have some atrophy over there. Possibly some calcifications, lateral calcifications in the inferior temporal region and also in the parietal region. There's a doubt of a cortical malformation, but the in the right frontal region and the perisylvian region. I don't think we had an MRI at this stage. 2016, at the age of 3, the calcifications have progressed. There is again asymmetrical dilatation of the lateral ventricle, some degree of atrophy on the right side as compared to the left. And also, I think there is some volume loss of the right basal ganglia, and also some Wallerian degeneration of the brainstem, the midbrain on the right side. The MR changes done recently. Persistent abnormality of the right cerebral hemisphere. There are some T1 hyperintensities along the parts cerebri, which possibly can be lipomatous growth. And the lateral calcification, which was seen earlier, demonstrates blooming on the SWI images. Post contrast, you can appreciate that there is leptomeningeal enhancement along the right cerebral hemisphere, predominantly in the temporal and the parieto-occipital regions. There's some abnormality of the middle cerebral artery on the right side, and the right cerebral antecerebral arteries are arising from the ACOM. So based on the findings, though there is no cutaneous abnormality, thought of a possibility of a type 3 Sturge-Weber syndrome, which can present with unilateral cerebral atrophy and leptomeningeal enhancement and lateral calcifications. Other neurocutaneous syndrome, though the cutaneous features are absent, but can have similar imaging features, were congenital melanocytic nevi, Parry-Romberg syndrome, encephalocranial cutaneous lipomatosis. So imaging wise, I could think of these differentials, or if it's a perinatal insult resulting in atrophy of the right cerebral hemisphere, but I think calcification and the T1 hyperintensities are not commonly seen in the acquired injury.
Nihaal, I would go with the Sturge-Weber syndrome in this case, given the gyriform calcification that you've demonstrated. And the atrophy would go with that as well. I'm just beginning to think that whether the eye lesion is actually, sometimes in Sturge-Weber, we can get a lot of hemangiomatous lesions or angiomatous lesions in even in the nose, and they cause nosebleeds. And that could be one of this. I know the possibility of melanoma was raised, so I guess it hasn't changed over the years. But I think it could be an SWS lesion, which could be an angioma per se. We've had angiomas in the internal auditory canals as well in these cases, or in the nose causing epistaxis. But I think the imaging, even though it's a port wine stain negative picture, I think would be consistent with Sturge-Weber syndrome intracranially.
But is it not extremely unusual, this kind of volume loss in the first few months? This is very unusual, I guess.
It is unusual. The whole hemisphere doesn't look small. But I think with Sturge-Weber, what is not known is the fact that there is actually a malformation of the brain associated with it. But that picture, when you see that coronal MR, with the contrast, etc., you have to call it in this particular.
This is actually a published case. I mean, from literature.
Go back one step, where you had the angiomatosis being shown.
Yeah.
But I get Eugen's point. It is unusual from that respect. And in fact, if anything, the skull vault is probably thinned around that area, which is what we would see in the port wine negative. Then the other point is about the angiogram, and you were showing some abnormality. Are you showing some abnormality on the MRA?
I think it's the normal variant of the anterior cerebral artery arising from the
that, isn't it? There's no
just
that. Okay, I think that can be possible, isn't it?
Yeah.
And no morphia, no scleroderma seen.
No.
I cannot imaging anyways.
No, I can see nothing there.
We had one case of Paedi-Romberg with porencephaly, but porencephaly is just a descriptive. I think we don't know the basis of how that happened. There was no congenital insult, but it's very few cases here and there.
And this is isolated in the family, no familial history, nothing, no one else with CP or.
You're thinking call for
no family history. No family history.
You still exclude a call 4A1, 4A2 mutation in this case, Biju.
I mean, like I said, Sturge-Weber seems to be the most likely thing, but in terms of genetics for other calcifications, I mean, if we exclude
the gyral calcification, pretty, I mean, it's less common in a call 4A.
Was that in the eye? Is that a corneal lesion or outside?
I'm not sure. It looks outside. I think there are two lesions.
It looks very much like a vascular lesion, that though, isn't it?
Yeah. Mary, do you have any findings from the ophthalmologist? What they have thought of?
Yeah, they put query of whether this is a limbal dermoid or melanocytic nerve.
Okay. So I had shown it to Dr. Deepa Tarnath, ophthalmologist, and she said melanoma and vascular malformation is a possibility.
Okay.
I think the biopsy and tissue that is similar.
Yeah.
Okay. So Sturge-Weber as the possible diagnosis initially, first diagnosis.
I think for now.
Okay, thank you.
Next case is from Kirti. Kirti, if you are here, you can take it ahead.
Yes, sir.
Yeah.
Good evening, everyone. So this was a 10 months boy who had predominantly motor developmental delay, like till 10 months had not even attained neck holding. but cognitively was age appropriate, had stranger anxiety, was playful, was waving bye-bye, and was born of third degree consanguinity. No, perinatally had some issues like there was significant, like there consistent with birth asphyxia. The child did not cry immediately at birth, had neonatal seizures on day 2 of life, as well as he was encephalopathic for 4 days. For that, kept in NICU for 7 days, though not ventilated. Feeding started on around day 8. So mainly for developmental delay, they had come to me at 10 months of age. And on examination, he had a head circumference of 42 centimeters, good vision, had fixing and tracking, but significant left hemiparesis, central hypotonia. There was significant head lag, and there was no weight bearing. So we're thinking of some structural etiology at this point, because head circumference on the lower side, hemiparesis, but also there was significant birth asphyxia. So perinatal insult was another clinical differential. So we can see the
And the
MRI.
TMS was negative.
TMS came normal, sir, normal.
So the MR at 10 months of age, you have bilateral symmetrical changes, restricted diffusion in the dorsal striatum, the thalami, the periaqueductal region, and the ventrolateral thalami. Also in the subthalamic region involving the brainstem, the vermis, also the cerebellar hemispheres, and also if you screen may look slightly below, even the cord is involved, the central aspects. You can also be appreciated on the sagittal T1s. You can see that the central cord demonstrates the edematous changes. The T2s changes are a little subtle as compared to the diffusion changes, but again, you can appreciate the hyperintensities in the brainstem and the cerebellum. Spectroscopy was done, very small lactate. I don't know how significant that is. No other abnormal peaks. So at this point, thinking of metabolic disorder, possible thiamine transporter deficiency with the involvement of dorsal striatum, brainstem, and the thalamic changes. Sorry. And also mitochondrial possibility based on the striatal abnormalities is what we're thinking. So organic acidurias, mitochondrial disorders, and thiamine transporter deficiency is what I thought on imaging at least.
How do you put in the callosal hypoplasia in there? And it's quite a large cerebellum. I don't know how you believe in this entity of the macrocerebellum.
But that could be, is it edematous and showing a large cerebellum? The secondary to edema as well.
That cerebellum is swollen, isn't it, on the
Yeah,
axial?
it's swollen. Yeah, it's
quite
swollen. So is it secondary to the edema, or is it just begin?
Yeah. I think so. In fact, there is tegmental swelling as well, isn't it?
Yeah, yeah. But I think lactic also was normal.
Callosum, frankly, of all the differentials you're saying, only a few of them would give you a callosum looking like that.
Mm-hmm. You would correlate with the perinatal insult, but there's some volume loss in the posterior perinatal regions.
Nowadays, when we say mitochondrial, clinicians ask us which mitochondrial does it look like. So I'm going to put the question back.
I would think empty DNA mutations because of the striatal involvement and the brainstem involvement. That's as far as I would go. And also thiamine transporter, solute carrier chain possibilities.
Looks like there's some swelling in the cord as well, isn't it? From that.
Yeah, there is swelling in the cord. I actually asked them to get a spine screening.
Yes, yes, we'll be getting it done in 2-3 days. They are yet to come back.
The perinatal injury history is not that strong in the history, isn't it? It's really, and slightly encephalopathic for 4 days, and otherwise.
Yeah, he was encephalopathic for yes, around 6 days. Had neonatal seizures, so I would consider that as significant.
So had seizures. Oh, okay.
Yes, had seizures.
That could be driven by the mitochondrial etiology as well, isn't it?
Yes,
mitochondrial problems can drive HI. So we are thinking respiratory chain. So we all agree on that here, Nihaal. I think they probably need a mitochondrial omics basically, but Have you all started the patient on your mitochondrial
Yes,
cocktail?
yes, I've started. Yes, I've started.
And have you managed to control the acute storm?
This child is now 10 months old. So this child is mainly following up for the developmental delay. So acute illness is not there not there now currently. So mainly evaluating for the developmental delay.
And had remained well for the last 10 months with no intercurrent infections where things.
No intercurrent infections. No, he has been gaining milestones slowly. Though motor milestones he has not gained, but cognitively he has been gaining milestones.
So what's the possibility of a completely isolated neonatal injury, perinatal injury? With
But would it show diffusion restriction at 10 months
that's
of
why
age?
I was asking Nihaal and Kesh, so.
No, it wouldn't show. No, it wouldn't
There
show.
may have been an HIE. In fact, there has been a hypoxic ischemic hit here. You can see that the mammillary body is burnt out basically. So this kid is going to have memory issues and all that. On that sagittal, I don't see a mammillary body. But I don't think the degree of callosal underdevelopment can be explained by a neonatal HIE. And I think the HIE itself could be driven by a mitochondrial etiology underlying it. So I don't think we should untwine them from each other.
What were the circumstances at birth? What was the reason? It was a normal delivery, wasn't it? Or
it was mother had some non-progress of labor. That's why it was prolonged for a long time. And then C-section was delayed, and that's why the child had some fetal distress, and then the child did not die. This was the story.
And they've got other normal children.
This is their first child.
So to evaluate for mitochondrial is the first possible.
Okay. Thank you. Thank you.
Is there optic atrophy as well clinically? That optic nerve looks quite thin, the chiasm as well, which would also favor a mitochondrial etiology in this case. I don't know what the vision is at 10 months.
He is fixing and tracking. His vision is good for his age.
Okay, thank you.
Okay, right. Thank you, Preeti. Please give us feedback if you get it. Case 6 are two cases. I just wanted to show them based on the previous discussion which we had with Dr. Vivek and Dr. Rashmi's case. So these are cases of presenting with positive history of hypoxic insult. But the imaging findings, as you can see, there are gliosis around the bilateral striatum. The thalamic changes, thalamus demonstrates reduced volume, but there's also hypointensity of the thalamus on the T2 variant sequences. The corpus callosum is thinned out, and you can appreciate these prominent lateral ventricles with some scalloping and volume loss. The T1 axis demonstrates slightly hyperintense thalami, corresponds with the dark thalamic changes on the T2s. And there's another case with the positive history for HIE and typical HIE changes. But again, you can appreciate that the thalamus demonstrates these dark thalamic changes. So previously, we had thought, there we have discussion of a possible metabolic or disorder. But just to add that hypoxic injury can also demonstrate these changes. And I think Dr. Mangal has CTs with calcification post-HIE in the thalamus.
I think what gives the darkness on the T2 is the calcification that happens in the thalamus. And the thalamus is, as we know, a cluster of 8 different nuclei on each side. And both preterm and term patterns of hypoxic ischemic injury can damage the thalami. It is quite vulnerable to any form. And this, of course, is a preterm pattern otherwise elsewhere, as you can see.
Yeah.
And I guess the neurology was non-progressive in this case, in both these cases. So we do have some CTs which show frank calcification. And if you are planning to put these together, which when I saw it many years ago, I thought this is a bit of a gap in knowledge. People don't consider the thalamus injury as a strong one in HIE by itself, that is. But it's the one structure that can, and Biju can tell us a little more. These kids should get dystonia, which is the main problem. But with the PVL pattern, there will be spasticity as well.
Absolutely. I mean, we've talked about this before, Kesh, isn't it? And often, I always notice the report coming back as low volume thalami, and that's always a red flag for me. And when you try to correlate it clinically, it all fits.
So both these cases are dystonia.
Yeah.
Just the other caveat to dark thalamus is when you have either a leukodystrophy or you have white matter immaturity, as in this case, there is frank scarring as well, the thalami automatically look a bit dark. So we do have a tendency to overcall it in instances of the white matter around being abnormal. But in this case, I think there is calcification, whether or not we see it on the MR.
Yeah, because when you look at the GRE SWE images, they don't show the hyperintensity in the thalamus somehow, in spite of this being a calcification, or somehow the GRE doesn't show it.
True, Vivek. In fact, I've stopped believing in GRE altogether. I think even for frankly calcified cases, it could be normal. I think what it would need would be a quantitative susceptibility mapping, really some kind of that measure. But I can give you CTs which was historically done with calcification, and it kind of adds to this cluster of entities showing a similar phenomenon. I could show you a companion case of thalami looking abnormal if you have time.
Do you want to do it now? I can...
Yeah, let me try it because I wouldn't be able to hide the patient details here effectively. But yeah, I'll bring it back next time.
Okay. Moving on to our next case, it was a term child with history of respiratory distress, sepsis, and excessive crying and breathing difficulty. There was seizure on day 8 of life with encephalopathy and subglottic stenosis. There's no history of birth asphyxia and was born to consanguineous parents. I think the scan was done at around 2 months of age, and you can appreciate these pretty autonomic changes in the diffusion sequences with restricted diffusion in the corpus spinal tracts, the pyramidal tracts, thalami, brainstem, the optic pathways, and also the cerebellum, which shows a swollen appearance on the T2 weighted sequences. And you can appreciate that the cord is also edematous and extending up to at least the visualized cervical and upper thoracic cord. Spectroscopy, we did a short and long intermediate T, which demonstrated this large peak at 0.921, which is attributed to the branch-chain amino acids or the branch-chain keto acids, and which inverts on the intermediate T. So this is intermediate. Though we don't have a genetic diagnosis yet, I would think that the maple syrup urine disease is the likely diagnosis for this case.
Yeah, it's definite. Did you need a spectroscopy for that?
No, we just put it because we had time. We didn't charge the patient for it. We just put it for academic use. Though I wouldn't think spectroscopy is required. Okay, move on to the next case. Next case is from Dr. Lokesh. Is a 13-month-old male child with normal development and no perinatal issues, was born to non-consanguineous marriage. Had febrile illness to development of acute encephalopathy and seizures within the next 2 days, which progressed in nature and had required ventilatory support and multiple antiepileptic drugs. There was a history of hospital stay for almost 20 days, and post-discharge, the status is the patient is demonstrating regression of milestones in both motor and cognitive aspects, has irritability, dystonia, paucity of the lower limb movements, and breathing issues. The labs, the CSF analysis was normal, lactate and ammonia was normal. TMS demonstrated mild elevation of the methylmalonic acid, and the autoimmune panel is negative. If Dr. Lokesh is there and wants to add anything, or I could go ahead with the images. Okay, I'll go with the images. We have 2 sets of images. The first scan was done on 30th November, and you can appreciate these punctate foci in the bilateral basal ganglia, demonstrating restricted diffusion, some asymmetrical involvement of the midbrain in the upper aspects, whereas you can see that there is more symmetrical nature in the lower midbrain and the cerebral peduncles. Demonstrates low signals on the ABCs. T2, there is mild swelling of the involved regions. And T1 again, there's no abnormality, and I think they did a post contrast, which I don't think was required, but did not show any abnormality. The repeat scan on 6 December, you can appreciate that the changes have progressed, go in a more asymmetrical fashion, now more completely involving the right basal ganglia and also the posterior putamen on the left. The brainstem changes are evident as seen in the previous scan. FLAIR again demonstrates the more confluent progressive nature of involving the basal ganglia. No abnormalities in the SWI, and spectroscopy demonstrated a lactate peak in the basal ganglia. With elevated MMA, the MMA and the TMS, I would think maybe mitochondrial would be first, maybe demyelination based on the patchy involvement, but it can be seen in metabolic disorders, though doesn't always need to be symmetrical in nature. And given the clinical progression, maybe metabolic first rather than a post-acquired demyelination is my thoughts.
It's only a mild elevation of MMA. I'm not a clinician, but how do you interpret that result?
I'm not sure about location.
Yeah, yeah. So yeah. The very significant worsening, the neurological status is quite significantly affected. He was apparently well child before that. So the degree of involvement and the progression is also not very significant on the radiology. Is that progression of the changes severe?
Yeah, there is progression. So this is 38th. As you can see, there are punctate foci, whereas in the scan after a week, you can see they are more confluent, especially on the right basal ganglia. So the basal ganglia structures are more, I mean, the changes are progressive in comparison to the scan done a week prior.
Well, how did you treat this?
So that's what we initially treated as acute encephalopathy secondary to inflammatory. There are inflammatory markers which were elevated. Ferritin was elevated. PCTs were also elevated. So we thought it was a sepsis triggering of a cytokine storm. So treated with IVIG as well and steroids, and later on things didn't improve much. After that, with this information, I think we added the mitochondrial cocktail as well, but not very sure whether it is due to inflammatory pathology or mitochondrial dysfunction.
And was seizures the main clinical manifestation, or were the neuropsychiatric
encephalopathy, and later on progressing on to significant motor regression?
But he's been well for 13 months, isn't he?
Yeah.
Dr. Lokesh, viral etiology was ruled out completely, I mean, in the CSF and all. Am I audible? Hello?
Yeah.
Sure, Kavita. Yeah, it was ruled out. There are no this one. PCRs were negative.
The history sounds very infective in its origin, isn't it? And then there is
the progression in radiology. Kish, could this be just just that the scans were early, and or was it just that?
Yeah, definitely. I think the timing of the scan is very important in seeing what we're seeing. But of all the differentials offered, I think none of them really suit this. And even for MMA, this is not typical. That's why I asked if the mild elevation of MMA is actually relevant at all.
I don't think clinically that's relevant. I mean, like I said, he's been fine otherwise, 13 months and then acute illness. So.
Nihaal, when you started showing the scans, I thought you were going to show us a biotin-thiamine disease, but looks like you've covered that ground anyways.
Yeah, the cortex goes.
Bilateral striatal changes, the common thing is still viral infections.
Yeah.
In 3 months' time, depending on the progress of the child. Thank you.
Okay, thank you. Moving on to our next case. I think this was a 3-year-old child, was apparently healthy but presented with squint on both eyes and dull activity, which progressively worsened sensorium. Currently, the child is comatose with no eye opening and yes, do you want to add? I'm not
Yes,
sure of the yeah.
this was a girl child around 3.5 years of age with a acute complaint of some squint developing on the right eye, and then there was a reduced speech output and overall dull activity, so in the form of some progressive encephalopathy, and then the squint developed on the other eye as well, the left eye. So for these complaints, she was managed at some private hospital outside, where CSF done was normal, and she was treated with some antibiotics, and then she was discharged on NG feeds because there was some improvement in the encephalopathy, but not completely. Like, she was just opening eyes and recognizing parents, but she was still non-verbal and pretty encephalopathic. She was discharged on NG feeds, and then gradually over a month's time, she's worsened further in the form that there is no eye opening to pain, just some flexion response was there and no vocalization, though the breathing is regular. And in terms of the brainstem signs, she has restricted extraocular movements, and she had hypotonia with brisk DTRs. So she has come in almost like 2 months of illness, and she's been managed outside. She came just last week in this state to us, and then we asked for a repeat scan. Images,
yeah, so this is the first scan done outside, and you can see that the bilateral thalami demonstrate edematous changes more around the left thalamus, but the significant changes are there in the brainstem. As you can appreciate, there is restricted diffusion along the ventral and central aspects of the brainstem. Some areas of cystic degeneration. The T2 signals, you can see that it is edematous and is expanding the brainstem, the pons, and also some nodular involvement of the right side of the medulla. This is the scan done on the 27th, that is almost 45 days interval. And you can see that the hydrocephalus have some in the ventriculomegaly has progressed. The brainstem changes also have progressed, and there is significant restricted diffusion involving the brainstem structures which were previously seen. And on the flares, you can appreciate the expansion of the brainstem changes, almost encasing the basilar artery, and extrapontine extensions demonstrated along the middle cephalopeduncles. The hydrocephalus has progressed and is demonstrating a significant periventricular edema. Corners, you can appreciate these lesions in the brainstem extending into the thalamus, demonstrating cystic degeneration, blooming on SWI, suggestive of hemorrhage or calcification. And on spectroscopy, we had this large choline peak. Possibilities thought of was embryonal tumors. This is the case from Dr. Mankad. Again, restricted diffusion, the extension into the extrapontine, extrabrainstem, and the thalamic regions. Other possibilities considered are diffuse midline gliomas. So yeah, we're thinking of neoplastic rather than infective or demyelination, and embryonal tumors and diffuse midline gliomas as the possibilities.
Yes, so with the clinical progression, so soon we were thinking of neoplastic more likely, and that's why pre-surgery we just wanted to have a current status for the lesions. That's why I repeated the scans.
Sorry, what surgery are you doing? Because the outcome of this is going to be grim. So do you really want?
We just wanted, yes, the surgeons actually wanted the current status of the lesion, like whether it's operable or not. That's why they wanted a repeat scan. So
scan is, but this is completely inoperable, and I think the child should be allowed to pass away peacefully, right?
Yes, sir. Yes, sir.
This is the diffuse midline glioma, and it's going to be an H3K27M mutant with hydrocephalus. Isn't that a good way to go?
Yes, sir.
I think
They're not.
we should.
I don't know. I'm just throwing it because this is palliation, isn't it, at this point?
Previous scans, we were just thinking for a biopsy, sir, but with the current scans, we are not intervening now, sir.
Okay, thank you.
This is the sort of ones they try infusion therapy, Kish.
What is infusion therapy, Biju?
Well, as in, like, in Bristol they were doing.
Yeah. So yeah, exactly. So it's convection derived.
Convection therapy, yeah. But I agree. There's no. I don't think there's scope.
We'll let you know with the biopsy results for the next meeting. Thank you. Case 10 is from Dr. Habib. I don't think he's there, but it's an 8-month male with developmental delay. Presented with neurodepression, I think after 5 months. Had dystonia, epilepsy in the form of spasms, was microcephaly, and had cerebral visual impairment. Paediatric history was normal. The scan was done at 8 months of age. And these are the T2 axons on top, and you can appreciate that there is significant volume loss involving the corticals, these peripheral aspects of the brain. The corticals mantle is thinned out. There's abnormal white matter changes and expected dilation of the active ventricles. But what is a striking feature in the case is the deep brain nuclear volume is relatively preserved, and it is demonstrating abnormal dark signals on the T2 weighted scans. Also, the cerebellum, you can see it's slightly darker. That probably can be in correspondence to the abnormal white matter changes. The brainstem demonstrates hypoplastic changes. There is some degree of Bowman hypoplasia. Correspondingly, T1 the deep brain nuclei demonstrates slight hyperintensities on the T1s. No abnormal signal foci on the SWI sequences, but on the T1, the axons, you can appreciate the significant volume loss in the supratentorial brain parenchyma. So once we saw that case, it reminded us of this case, which was done a few months back. It was an 8-month child born to third-degree consanguineous marriage, had global delay, progressive microcephaly with infantile spasms, had an hyperpigmented patch on the left thigh with alopecia and bilateral hamstring spasticity. And the imaging you can appreciate is almost identical to the index case. Again, severe volume loss with preservation of the deep brain nuclei and dark T2 hypointense changes, especially in the base ganglia and the thalamus. Again, thinned out corpus callosum, no changes on the SWI sequences, no change on the diffusion sequences. That case came out with a variant of a TRAP-C4 gene, which belongs to the trapopathies, and the published literature also can appreciate the imaging findings are pretty identical to both the cases which we have seen. The differentials before we got the genetic diagnosis was though unlikely in NCL and biotinase deficiencies and other mitochondrial disorders.
With the trapopathies that we've had, severe and very accelerated neurodegeneration was noted, as in your cases as well. We also picked up some, well, it was called cyst formation, but I think I don't think that was a cardinal feature. You just have rarefaction of the ventricles and the white matter. This is a good example of where, because the brain and the white matter is so abnormal, the deep gray structures appear really dark. It's a relative grayness that you see.
Atrophic as well.
Sorry, someone said something.
Atrophic as well, Kesh? Nihaal?
No, they're not atrophic. This is, though I don't have a thalamic cut, the thalamus was normal. You see, they're not atrophic. They demonstrated.
Thalami looks small, though. I think Lokesh is right. They are quite small, the thalami, isn't it? But that could be a reflection of the overall neurodegeneration that's happened, because the whole brain is atrophic.
Yeah, okay, not as a primary process, but as okay.
Dr. Maka, any posterior fossa changes in your typopathies because it is hypoplastic?
I'll have to go back and look at them more carefully, to be honest. You brought that discussion back and it was just contemporaneous to what was being discussed here. But if you all do end up wanting to write the case series, then I can connect you with Pinky out here who's leading on them.
Okay.
We'll be happy to collaborate.
Yeah, sure.
Okay. Moving on to our next case. It's Subi. Do you want to take over?
Yes.
Yeah.
So this was an 18-year-old female born to fourth degree consanguineous marriage with was a second born. So she had a developmental delay, started walking with support at 2 years of age, and then after that she had a gradual and progressive regression. So when she came to us for the first time at 18 years, she was bedbound. She was not able to sit on her own. There was no neck holding also, and even cognitively she was just able to recognize her parents. There was not much of speech output. Along with that, she had a bilateral hearing loss. It was a sensory neural hearing loss, and on examination she was having significantly failure to thrive, and spasticity was there. So there were pyramidal signs in the form of spasticity in both lower limbs more than upper limbs, as well as contractures were there, but there was areflexia in the lower limbs. So with the upper motor neuron and lower motor neuron signs, we were thinking of maybe MLB or mitochondrial as the differentials.
We have the images, but the images are at the age of 4 years. So these are 14 years back, I think around 2007. We'll see what we see. You can see that there are restricted diffusion in the more on the peripheral aspects in the subcortical regions. Ventriculomegaly is demonstrated on both the lateral ventricles. On the T2s, you can see there is some degree of volume loss, cerebral and cerebellar regions, some volume loss of the brainstem. And you can appreciate these areas of almost symmetrical changes in the subcortical or the peripheral aspects of the cerebral hemispheres on both sides, sparing the deep white matter. The basal ganglia and thalamus do not demonstrate any abnormal signals. Also, you can appreciate on the diffusion sequences, there is some differential areas of restricted diffusion, whereas the central areas demonstrate restricted diffusion and the posterior regions do not demonstrate restricted diffusion. Sagittal images, there is thinning of the corpus callosum, volume loss of the brainstem, cerebellum, and the cerebral structures. Similar changes seen on FLAIR. So at this point, though the scan was done at the age of 4, that is 14 years back, thinking of leukodystrophies with peripheral white matter predominance in the form of L2-hydroxyglutaric mitochondrial Kearns-Sayre syndromes or TACO1 mutations. Propionic acidemia and nucleocycle disorders are probably less likely given the imaging findings. So these are cases from literature, and the Kearns-Sayre syndromes can present with hearing loss, though can have the triad of the heart-eye changes, which I don't think are present in our case. The differentials of the subcortical are the Kearns-Sayre syndrome, TACO1 mutation, that is translation disorder, L2-hydroxyglutaric. The anti-nucleus changes are absent, and according to the CHOP group, what they found is a differentiating factor for Kearns-Sayre and TACO1 mutation is these areas of sparing of the white matter, these linear strands, which are commonly seen in Kearns-Sayre as compared to the TACO1 mutations, which is also seen in our case. So imaging wise, thinking of mitochondrial with the possibility of Kearns-Sayre. I don't know if a scan will be helpful now at the age of 18 years, because the scan was done at age of 4. It does not look like a MLD, if that was a mental suspicion.
I think we've asked for genetics like whole exome with clinical with mitochondrial. We'll be getting results in maybe 2-3 weeks. Thank you.
I think here the problem is whole exome with mito will not pick up Kearns-Sayre. Kearns-Sayre is a deletion, mitochondrial deletion disorder. So you have to specifically request for KSS, specifically. So mitochondrial sequencing will also miss it.
Okay, so we'll pass it on to the genetics people, so the added information.
Can I jump in? I think
Yes.
the clinical dynamic is not really suggestive of Kearns-Sayre syndrome. A child who makes regression already at 2 years and loses ambulation, this is very unusual.
I agree with you again, because normally the few Kearns-Sayres we have seen, they usually develop ophthalmoparesis with the degree of ptosis by this age.
They
And
go for many years, and then they have cardiac involvement, retinal involvement.
For this child, the vision was relatively spared. The extraocular movements were all normal, and there was no cardiac involvement, sir. Like
it
at
will be
least
very
clinically.
odd. Very odd.
What's the story, Nihaal? They were okay till 2, and I did not read that correctly.
Excuse me?
Were they okay till 2 years of age, and then
She had a developmental delay, like she just started walking with support by 2 years of age, sir.
and then from 2 to 16, how has their life been? Just ongoing regression and hearing loss, or has she been stable?
She started losing the milestones gradually. By around 4 years of age, she became non-ambulatory. And then later on, when they evaluated at that time only, they found that she had bilateral hearing loss as well. So from that time, she's been almost bedbound, sir.
But no intercurrent episodes of flare-ups and metabolic or mitochondrial disease?
No.
None of that. That is quite unusual, isn't it? And I would agree with Eugen.
Would you advise a scan now, Dr. Pankaj? That present scan, just see if the changes have evolved or?
Probably not. I think why put her through all that scanning when the neurology, in a way, she lost everything and then it has kind of stayed there, isn't it? It'll be just an academic interest for scanning her now. Was she exposed to any toxins or anything like that around the time of the age of 2 and 4? Because these are the typical areas where things like methotrexate would hit the brain, for instance. And then she has cavitation, leukomalacia, and brain volume loss following that, isn't it?
Did not ask it specifically, sir, but like she was
Prove
in
anything.
hospital.
I don't think we will resolve this case in 16 years.
Very strange. Mitochondrial is still on the agenda, wouldn't it, Eugen?
Yeah.
Always is.
Yeah, I mean, particularly with the hearing loss and the combined upper motor neuron, lower motor neuron signs, and very strange.
We'll probably get back to the exome sequencing if it picks up anything.
Yeah.
Case 12, Sahil, if you're there, you can.
Yes, sir. So this child was a 6-year-old male born of second issue of non-consanguineously married parents, had sudden episode of giddiness after playing, and followed by that he had vomiting, and then he had weakness of all 4 limbs. And then he presented to us with a good GCS of 15/15 with no cranial nerve palsy. Tone was good. Tone was hypotonic with just +1 reflexes. Gradually, the weakness improved with the involvement of right upper limb with power of 2/5 and the rest, which was 4/5. So the child has this episode of giddiness after playing. So a possibility of dissection was kept.
In the MR images, you can appreciate that there are multiple areas of ischemic stroke-like lesions involving the bilateral cerebral hemispheres. brainstem and also the occipital region on the left. The spina of the corpus callosum also demonstrated a focal ischemic lesion. No hemorrhagic transformation on the SWI. The angio, at least the MIP images, do not demonstrate any significant abnormality in the major vessels. And the source images, I could not find any abnormality, at least on the MR angio. The vertebral arteries were normal, and also the basilar arteries are normal, which is not shown in the sequence, but it demonstrated normal signal changes. The left posterior cerebral artery was slightly hypoplastic compared to the right, and vessel wall imaging was done. There is some perivascular, only on the outside there is some enhancement, but I don't think any intraluminal enhancement or thickening involving the vertebral arteries. No luminal compromise, no stenosis, no thrombosis. I think the CT scan also was done with a CT angio. Cannot appreciate any craniovertebral junction abnormalities. Just pay the CT angio. The angio, at least the vertebra and the basilar arteries demonstrates normal appearance. Yeah, so these are the images. Dissection, I'm not sure if it's can be called out based on the images at least. I don't think we had a T1 PAT-SAT which can sometimes see the lumen.
Can you go back to the MR?
Yeah.
Sorry, I had a caller come through. I'm covering the hospital alone. I love the conversation where you were describing posterior fossa infarcts, and you said that the MRA was unremarkable. But I think in the context of posterior fossa infarcts, there should be a very low threshold to do a DSA. And I think you're dealing with a scenario of vertebral artery dissection or in that realm, basically, whether it's unilateral or bilateral. But I think you need a DSA in this case.
So,
these
good
are
evening, everyone.
cerebral infarcts. Yeah.
Yeah. So, if the CT angio and this thing is normal, still, do we need a DSA in this case?
Yes, absolutely.
Okay. Okay. And the other thing was, this is a case like Dr. Vivek had presented last time, though he had very small infarcts, and this child had very high levels of COVID antibody positive. That was the only thing we found. And D dimer was also very high, 3000 something. And there was no other inflammatory marker which was raised. So we were thinking of a vasculitic kind of pathology. And I think the vessel wall enhancement was also there, Dr. Nihaal?
Not within the lumens, just outside. I wouldn't call it a vasculitis. It is causing the infarcts.
And the vessels that you're showing as enhancing are actually anterior circulation, right? Where are you exactly?
These are the vertebral arteries.
Okay, vertebral arteries.
Yeah.
Because what was reported was that
after traumatic dissection, you can have enhancement of the vessel wall as well. So it's not really helping you here. I just stopped believing in time of flight MRA for posterior circulation infarcts altogether.
Okay, so in such a scenario where you get a posterior fossa, posterior circulation strokes, like what should be the optimum imaging that should be advised?
I think CT angiogram first, which will give you a lot of information if done correctly. This is a 16-year-old, mind you, so they are behaving pretty much like an adult. And if it's going to
this child is 4 years old.
Okay, 4 years. But if it's, first of all, if you decide a CT angio should be done, and if that's also unremarkable, and then you're thinking about a 4-year-old, I think a lot depends on how your management is going to change. If you really want that dissection proven in these cases, then you should do a DSA. But if you're going to treat empirically for a dissection anyways, then I think that's fine. But I think until and unless we have a DSA as a gold standard, we can't exclude a dissection.
Okay, thank you. So this vessel wall enhancement doesn't really suggest vascularity, because I thought it was related to that inflammation and MISC kind of picture because of very high COVID antibodies and D-dimer, etc.
It may well be, but all these are diagnoses of exclusions, right? I mean, a vasculitic infarct only in the posterior circulation in a child who's got COVID everywhere is unusual, isn't it, in the context of having giddiness post-football injury?
Mm-hmm. So he was on a merry-go-round kind of thing, and that's why we were thinking whether there is a dissection and all. But without DSA, I think we cannot rule it out completely. I think that is what is the message. Okay.
And I think in young children, the spontaneous dissections can also happen. They jump into a swimming pool. Biju will agree, we've had so many cases here, trampoline injuries, and they've mostly the imaging does not pick up anything obvious.
Trampoline, surfing, rugby.
Okay.
Even with skating as well sometimes.
Skating, yeah.
Can you say a word about the prognosis? I think it's not bad, even in bilateral stroke.
Okay, because I was like a skeptic how long to give the steroid, because I started it on this diagnosis of vasculitis on the MR, this vessel wall enhancement, and with such high D-dimer and all those things. So I was not sure whether to really label it as vasculitis or still go ahead and do DSA for ruling out dissection. So now, once like this acute stage has already passed, will the DSA still be helpful? Like almost now it's 2 weeks since the
Potentially
last.
not. My question to you is, Kavita, are you treating for stroke as well, or just some kind of inflammatory process? Or?
No, so I had started low molecular weight heparin and all, just because there is a this very high D-dimer. I mean, as a protocol for the MISC thing, though he's not having all the features of MISC. So I have not treated anything specifically for the stroke part, except giving aspirin, which is anyways controversial in
True.
such a scenario.
I'll be straying out of my comfort zone in terms of how we would manage this.
Because once we at least ruled out a major dissection on the CT angio, I started on aspirin. But again, this is open for discussion. You know, Vivek and all can maybe Lokesh can.
Dr. Lokesh, maybe can, what you seen?
Yeah, can you comment like what could be the? Though this
Yeah,
is more
sure.
of neuroradiology, but yeah.
The management part of it, or we talking of?
Yeah, management.
Yeah,
So
I think
dissection has not been completely ruled out, as Dr. Mankad said. Yeah, but I mostly probably it may be normal only.
Yeah. So the therapy with low molecular weight heparin initially, and then shifting over to aspirin as we do usually in UK once we have ruled out the dissection. Other important aspect, we just had another child with similar extensive stroke where we had to decompress him because of significant edema, posterior fossa edema, and compression on the medulla, and then to require tracheostomy and get him out of the ventilator. So those things have to be anticipated, especially in posterior circulation strokes.
The other thing I wanted to ask in this like MRI picture, like how does it explain the initial quadriparesis, or was it just a neuronal shock kind of thing? Because initially he had complete quadriparesis, and then over a few hours then he improved, where he was left with just right-sided hemiparesis, and mainly more of upper limb, of course. Is there anything to suggest a brainstem affection as well?
Yeah, some aspect is there on dorsal brainstem. You see over here, these superior cerebral peduncle is involved. There's some compressive
So
effect on the
bilateral,
brainstem.
how do we explain that? Or I mean, maybe just non-specific.
Would the compression cause the symptoms? Though I think initial presentation would not be there based on the edema histories.
Yeah, because when the parents actually, what the mother reports is when she took her from that that swing, the child was completely quadriplegic initially, and then when the child was brought to the hospital, also there was hardly any power in all the 4 limbs, and then gradually over a few hours, then the other limbs recovered, and he was left with the more of a right upper limb more than lower limb affection.
Kavita, I think that's quite well explained by the fact that you have bilateral cerebellar infarcts and close to the foramen magnum, there would have been tremendous swelling to start with, which would have impinged on the cervical spine at the higher level. The quadriparesis being transient can be explained by that.
Okay. I think that seems plausible. Thank
So
you. Dr. Biju, any comments on the management?
Did he have COVID and raging inflammatory markers at the time?
No, he never had COVID. In fact, in last 6 months, there has been no febrile illness in the whole family. And in this child, even in the CSF, we did the COVID antigen PCR, which was negative. And even IgG, just for a non-specific inflammation, also we did in the CSF. That is also negative. CSF routine is negative, normal. There is no other inflammatory marker except for the high D dimer, which is 3000, which is pretty high. And even the COVID antibody titer was I think 1076 something, which is supposed to be quite high. So that was the only thing positive which we found. 1018 was the COVID antibody titer.
But I think, like you said, everything else points towards a traumatic dissection here. And like Lokesh said, the management would be the same. But I don't think there's any problem in giving steroids. You can cover for everything anyway.
No, I started because I thought of this, vessel wall enhancement suggestive of vasculitis, as well as the
it's not going to do any harm.
Partial MISC kind of thing.
The swelling, yeah. So
okay. Thank you very much. So I think Vivek had shown a similar case last time where there were multifocal infarcts, and that's why I wanted to discuss this case. Yeah. Thank you.
Would you, in terms of advising when he is all well, Eugen, and in terms of, you said the prognosis is good, but in terms of his physical activity, what would you suggest? Can he go back to his normal routine?
I've seen only one patient who with a similar bilateral lesions, and he was, without sophisticated testing, he was back to normal in daily activities in a few weeks.
Amazing.
Yeah, I agree with that. Whatever posterior circulation strokes we have had till now, most of them have done well. Though I will have to actually go through the whole data and all, but generally not a bad prognosis.
Who needs a cerebellum anyways, right?
No, we don't know the long-term outcome. Maybe, their cognition and all, we don't know what happens to their long-term outcome. But at least short-term wise, the next case I think will demonstrate that. Let us see.
Yeah, that was the exact dilemma we had when we were actually operating the posterior fossa decompression we were doing. When I have a child who had exactly almost similar extent of lesions in the posterior fossa. Whether he will ever be ambulant independently, whether he will be able to have independent life. But ultimately we decompressed at that point of time. We have to wait and watch.
Thank you, Dr. Upesh. Next case, Sahil. I think this is a follow-up case. We initially discussed this in September. Just a brief clinical scenario, Sahil.
Yes, so this child is a 3-year-old female, first issue, non-consecutively married parents with normal perinatal and developmental history. Initially, she had come to us with sudden loosening of all body with headache, and also after the later on, she developed left hemiparesis. Gradually, the weakness improved. Now it's good power, and she had come for follow-up. So her APLA stroke profile, which was done, which was normal, COVID antibody cycling, everything was normal. So here we, so 2 imaging modality has been done, MRI twice. So we wanted to compare.
Yeah. So no recent abnormality in terms of the clinical?
No, sir. No, not clinically. No.
So just
clinically, child has completely recovered. Yeah.
Okay. So these are images which we discussed in September. Again, bilateral cerebellar stroke, ischemic lesions. also involving the brainstem. At that time, we probably commented that there is some paucity of the thecal spaces in the cervicomedullary region or the upper cervical cord. The angio demonstrated lack of flow in the vertebral artery on the right and also the basilar artery. The venogram demonstrated normal appearance. And this is the follow-up scan. As you can see that there is gliosis and encephalomalacia involving the regions which are initially involved in the scan in September, and angio was done, and the angio source sequences, you can appreciate that there is hypoplasia of the bilateral vertebral arteries and also the basilar artery. The mid and proximal segments of the basilar artery are faintly visible. The proximal segment was more clearly visible. CT angio also was done and demonstrated similar imaging findings. Yeah, so that's the case. There is some revascularization, but it is still hypoplastic is what I think. And I think clinically it is patient has improved. So I think that was the importance of this case. Dr. Kavita?
Yeah, initially, like post recovery, she did have ataxia for some time, but now that has also improved. And again, here, I think the vessel wall imaging showed some enhancement, along with, of course, the multifocal narrowing of the vertebral artery and so on.
Yeah.
So again, here I was not sure what we are dealing with, though we did not find any of the inflammatory markers raised. So in such cases, just on the basis of vessel wall enhancement, how sure we are about vasculitis, and do we treat them with steroids? These are real dilemmas that we face. So that's the reason to discuss this case here. So if we get vessel wall enhancing, does it always mean, this question I think I asked last time also, does it mean that there is a vasculitis and that is causing the this hypoplastic like appearance, or is there any other way to find out whether it is a progressive process or it's just a hypoplasia?
I think the threshold for vessel wall imaging has not been established. Vessel walls will normally enhance if you give a good whack of contrast, because the vessel wall itself is perfused. So it will pick up some of that contrast. But smooth, linear enhancement, I think, should be treated with caution and not labeled as definite vasculitic processes. The examples that people show of vasculitis is very thick rinds of enhancement, irregular, not symmetrically involving the two sides. But I think if you give enough contrast, everything will enhance.
Okay, so in this child, like, how do we find out whether the posterior fossa structures are well perfused, and there is a, like, what is the risk of getting another infarct, because both the vertebrals are hypoplastic here, and she has already got one infarct with the gliosis. So like, what kind of imaging, perfusion imaging, or what kind of imaging can help us to decide, because we have not found any kind of compression, extrinsic compression, or any kind of vasculitic process. So with the hypoplastic thing, what is the way to find out the level of perfusion?
I don't think
and
you
the
can.
risk of another.
I don't think you can. Typically, they just followed up clinically, out here at least, and in fact, many of them end up having surveillance scans on an annual basis to make sure the vasculopathy is not progressing. I don't think there is any modality that can predict that this is about to infarct and let's start neuroprotection. The other question, of course, is about neuroprotection, as to how long you would give it for at baseline and then continue it or discontinue it. But that's a question for you guys.
Yeah, Dr. Biju, Dr. Eugen, your comments?
It is very unclear, Kavita. We've had this sort of similar situations before, and it's very difficult.
It's nice to know that because so many times we feel that
But that's what I
said.
Like, we've been in similar situations where we have thrown everything because it's very difficult. And we've had fights with radiologists about vasculitis, not like you are having. So it is very confusing.
Okay, thanks. Dr. Eugen, any comments?
Not really. Well, you give this patient aspirin, am I correct?
Yeah. In fact, I had given steroids also because the
question was how long?
Sorry?
The question was the duration of that treatment. Am I correct?
Yeah, like how to go forward in this case. That is the question, because the vessel wall imaging did show some enhancement, and on the basis of this, we had diagnosed her as vasculitis. But we are not sure about it now, and the vessels remain hypoplastic, the vertebrals, and there is always a risk of another infarct then. So how do we go ahead in this?
As we said, I would be hesitant to call this vasculitis in the proper sense. It's a local finding, as this can also be seen in anterior circulation with so-called transient focal arteriopathy. It's a local kind of inflammation. Whether you give steroids or not, I think it's not yet proven whether this is helpful, but it's not a risk to give it temporarily. And otherwise, I don't think you can do much apart from giving aspirin for open end.
Okay, thank you. Any other comments from anyone else? Dr. Vivek, Dr. Lokesh, Ramesh? Okay, thank you.
Right, thank you. We'll just moving on to our last case. If Dr. Vivek wants to describe the clinical scenario.
So this is a 15-year-old girl. She had a background of mild sensory neural hearing impairment, for which she had hearing aids. Since around 10 years age, she had been having episodes of right-sided transient hemiparesis each time with a febrile illness, which will last for just 2 to 3 days, and that will resolve. So family had shown to a few doctors, and because it will resolve, there was not much done for it. So last 5 years prior to this event, I think 4 events she has had of febrile illness with transient hemiparesis, always on the right side. This time she had 4 days prior to being admitted with us, 4 to 5 days, high-grade fever, during which COVID was negative, was done locally. She had again the right-sided hemiparesis with right-sided ptosis as well. So there was partial third nerve weakness on the right side because pupillary reaction was preserved. So same side ptosis and same side hemiparesis. And that happened on day 2 of the febrile illness. And soon after, she developed a severe bilateral facial rash, lividure reticularis on the legs, and legs became cold and clammy, and then it just evolved into purpura fulminans in the legs. So even though in the history I've written transient episodes, right and left side weakness, they were always on the right side. So I did check that. So when we did the workup, her CB's complete blood count had shown a leukocytosis with thrombocytopenia, 60,000 platelet counts. The blood film didn't show any evidence of intravascular hemolysis, so we could not explain that. But because of this rash, hemiparesis, even though there was a history of previous episodes, we thought, could this be SLE or some form of, P-ANCA or some form of vasculitic illness, known mixed connective tissue disorder. So that was the initial differential. Her CPK was very high as well. So then we thought whether this could be antiphospholipid antibody syndrome with muscle infarcts as well, which is causing the high CPK. So, the mixed connective tissue disorders were more of differential, but still we could not explain the previous episodes of hemiparesis and the sensorineural hearing impairment. So we did think that is it DADA2, which is sort of underlying genetic disorder which she has, and each time she has a mild vasculitic-like illness. So that was what, and ESR was 40, so mildly raised. And then over the next few days, while she was with us, she had to be ventilated, and the hemiparesis and ptosis persisted on the right side. and she really developed this severe bad purpura fulminans, leading to more like, the skin was becoming gangrenous. So we had to start her on, we gave her steroids, we started her on Clexane as well, even though platelets were low, but we were but we gave it. There were no other options. Yeah, that's what it was. And we also gave her tocilizumab, because we thought, is there a cytokine storm? So that's what we started. She was being ventilated. It's been just few days and she's status quo. So she's still on the ventilator, the same state, the pictures you see. She's been with us for last 8 days now.
But developmentally normal and no issues.
Cognitively normal before that, but again the problem is, even though they say cognitively normal, because she had a sensorineural hearing impairment, often one ends up thinking the child is cognitively impaired, but it's more the speech which is affected. So for them, I think she was cognitively normal, except for the sensorineural hearing impairment.
Okay. So just show the, sorry.
Yeah.
Just show the images. You can see that there is abnormality of the anterior aspects of the lateral ventricle. The septal leaflets are absent. This gives like a box-shaped configuration. There is a recent stroke involving the left peninsular region. The right posterior peninsular region and the peritragal region demonstrates this focal hyperintensity, which does not demonstrate restricted diffusion, likely a old ischemic process. There is the dependent portion of the occipital horns demonstrate these areas of restricted diffusion. The contrast wasn't done whether these are debris because there is no corresponding changes on the SWI to suggest bleeding. The corpus callosum is abnormal, and also if you appreciate on the coronal images, the olfactory bulbs and nerves are hypoplastic. Again, there's a box-like configuration because of the absence of the septal leaflets. No hemorrhagic foci in the brain. So we're dealing with ischemic lesions of different stages and possible debris in the ventricles. Probably contrast might be helpful. And also the spectrum of septoptic dysplasia type pattern. So given the clinical possibilities, DADA2 syndrome, the neurological manifestations, they present with ischemic strokes, lacunar strokes, cranial palsies can be there, hemorrhagic strokes can be present. And this is a recent paper on the DADA2 mutation syndromic changes. At least the neuroimaging demonstrates hemorrhagic strokes. Some perivascular enhancement can also be seen. And they can also have subarachnoid hemorrhage with aneurysms. The other clinical differences of the A+ syndrome, they also can have ischemic lesions in the form of large territorial infarctions or lacunar infarcts. Basal ganglia lesions and corpus callosum lesions can be seen. Thromboembolic strokes can also be demonstrated with hemorrhage and white matter lesions. They can also have focal cerebral arteriopathy or stenotic lesions. So based on the findings, changes of stroke, which can be seen in the connective tissue disorders, but the septoptic dysplasia pattern, I don't think neurologically correlates, or if there are no changes in olfaction or vision. Any endocrine abnormalities or vision abnormalities, Dr. Vivek?
No vision or endocrine abnormalities.
Okay.
Did the angio come through? Did not the angio come through?
I don't think so. I had an angio. But these are small vessel strokes, so I'm not sure if we'll be able to pick up on the.
So angio was normal.
Yeah, that is expected because the vessels are small vessels, so I don't expect.
Also wondering about the debris in the ventricle. Is it purulent? Is it what it could be?
Possibly bacterial exudates, because that is most commonly seen in the form of ventriculitis type.
Procalcitonin was normal in spite of, is it severe inflammation, accumulation of cells? Can that cause purulent-like material in the ventricle debris? No, non-infectious inflammatory storm. Can that cause it?
I'm not sure, but I would just think infection is the first possibility.
For us, that is pus or hemorrhage until proven otherwise.
Yeah. But isn't DADA2 and the antiphosphate associated with infections? At least.
Yeah, I mean, immunodeficiency is associated, isn't it?
Oh yeah,
Yeah.
that is true. I'm just talking about the ventricular material.
Yeah.
It's just odd because the ventricular margins. So I'm not sure if the contrast came through, but the contrast, there was no ventriculitis.
Yeah, but there is debris in the ventricle, so that is a definite finding.
We couldn't do a CSF because the platelets were too low, and we are giving a Clexin already.
But separately in purpura fulminans, you get these sort of pictures, isn't it? With hemorrhagic infarcts and. But I mean, this is different. But she's had hemiparesis before, but now she's acutely unwell with purpura fulminans, isn't it?
So Biju, what are you trying to come to? Like,
these are acute pictures, aren't they?
Yeah.
And she has purpura fulminans now.
Yeah.
So I mean, hemorrhagic infarcts are quite. You see strokes with purpura.
There's no hemorrhage, but these are infarcts.
Yeah.
They're more lacunar kind of small vessel ischemic changes of different stages. So.
And she's immunocompetent, is she?
We did an immunoglobulin profile, which is normal. Because we thought it could be CVID, common variable immunodeficiency, presented with, they can have autoimmune disorders, but immunoglobulin profile was normal.
Right, Nihaal, if you have time, I could share my case, which I was going to show to you all, or we can bring it up time.
Yeah, I have. I'll just show one. This is just a follow-up case which we discussed from Dr. Kavita. I'll just show the images quickly. These cavitatory lesions in the cerebral white matter more confluent along the posterior aspects. At that time, we suggested a possibility of a mitochondrial disorders, and this came out to be positive for complex flow deficiency. Yeah, Dr. Pankaj, you can take over.
Let me see how
This
to.
child was actually now in a bad shape on a ventilation. The last what I heard was probably they were thinking of weaning him off. So he deteriorated very fast after this.
Pretty bad. Don't worry, I can bring it up next time, Nihaal. Like, I don't know how to share the screen here because I think your admin person will have to do all that on this particular platform.
Okay.
It was just a case of an SPG4 and with thalamic changes as well as very subtle dentate changes. Just to kind of close the loop on where we started the discussions today, but it's a confirmed SPG4 case with the central tegmental tracts as well, which was there in your initial case.
Yeah.
That's fine. We can see it next year.
All right. Yeah. So yeah, Happy New Year to everyone, and probably we'll hopefully have more cases, learning and collaborations in the next year.
Yeah, it was very useful. Thank you so much to all of you.
Thanks, guys, and Happy New Year.
Thanks. Thanks, Kavita.
Thank you, everyone. Thank you, Dr. Biju. Thanks, Dr. Eugen and Dr. Mankar. Thank you very much. Happy New Year to all of you.
Yeah.
Happy New Year. Happy New Year.